Assalamu alaikum. Good evening, everyone. It's my great pleasure and honor to introduce our distinguished speaker today, Dr. Sameh Galal, consultant of Pediatric Ophthalmology and Strabismus, and head of the Pediatric Ophthalmology and Strabismus Department in Research Institute of Ophthalmology in Egypt. Dr. Sameh Galal, high respected expert in the field of pediatric ophthalmology and strabismus. Today, he will be describing glasses eye care provider and essential for every ophthalmologist involved in the management of children with refractive errors and amblyopia. The lecture will be delivered in English language, but the discussion after that could be in Arabic language. Dr. Sameh Jalal, you are welcome.
Thank you, Dr. Muhammad, and thank you, Dr. Abdurrahman, for inviting me for this course and starting with this nice lecture. It's my honor to deliver such basic knowledge because I think prescribing glasses is very important in ophthalmology practice. I think it's much more popular and more important than doing surgeries because,
احسن صح؟
okay, is it
Yes,
fine now?
yeah, it's fine. Yeah.
Okay. So again, giving glasses is one of the most important topics in ophthalmology in general, but in pediatrics, it has a special place to tell about because the child will never tell you what exactly he sees, and you have to have your own plan to go through the visual recovery journey with a child. So I apologize for being much basic in the start because the basic knowledge I think most of us is not aware of, especially in pediatrics. So I have to revise for my own sake and for yours, the basic knowledge about prescribing glasses in children. So let's introduce with that. It's determining refractive status of an infant or a preverbal chart is usually done using objective refraction. So it needs great expertise, which is needed to judge alternate fixation as well as light thickness, brightness, and movement of the retinoscopy. So refraction, usually not most of people have portable autoref. And even if you have portable autoref, you have to know by heart how to do retinoscopy properly in a child and in adult if he's not cooperative. And again, it's very important to verify the refraction you got out of the autoref in most of the cases. So knowing the refraction is very important, how to do it, not just autoref. You have to know by heart how to do retinoscopy in pediatric ophthalmology practice. Again, the second question that will come to my mind, what are the indications of cycloplegic refraction? Because usually when you are sitting in your clinic in real scenarios, you ask yourself, do I have to do cycloplegic refraction or should I go just for refraction either by autoref or by retinoscopy and come out with these numbers to write it down in a card? But we have special indications to do cycloplegic refraction. And by the way, the default is what
Dr.
we do
Sameh,
cycloplegic
sorry for
refraction.
interruption, but please share your screen again.
Okay.
Okay.
Is it fine now?
No. Okay. Yes, you can continue.
Okay. So going back for when to do cycloplegic refraction, usually we do in all cases of children under age of 5, especially if we have special situations, like if you have best corrected vision less than expected, if you found a child showing normal refraction or almost normal refraction with unexpected corrected or uncorrected visual outcome or visual acuity. If you have strabismus or amblyopia, it's very important to do cycloplegic refraction. If you are suspecting a malingerer or hysterical patient, many times patients came to our clinics telling we don't see well, and putting on the autoref, you find normal refraction. But when you go for cycloplegic refraction, you have many surprises. So cycloplegic refraction is very important to differentiate between malingerer or hysterical patients and real complaining refractive error patients. Let's go again for the next slide, which is how to do cycloplegic refraction, because most of us in our real practice, we just ask our nurse or assistant, please dilating eye drops for the child to check the refraction of after putting dilating eye drops. And many times when you don't have a plan to do psychological refraction or a real refraction, you just waste your time putting drops till you revise or call someone by phone from consultants, of your contacts to ask him, I have a patient of cylinder -3 or spherical -4. Again after 3 days. This is one of the most common mistakes in pediatric ophthalmology practice, to prescribe cyclopentolate and ask the patient to come again after 3 days. So before telling what to do in psychological refraction assessment, we have to go for this important slide. Because if you went through dilating eye drops, we have many types and many categories and many pharmacological categories as well. You have atropine, the father and the mother of dilating eye drops, which is called parasympatholytic drops and is the main parasympatholytic drop. So it's used for midriase and cycloplegia as well. And actually, it is the strongest one. But what's meant by strongest? It means it causes complete relaxation of ciliary muscles, giving you a good idea about what is the total refractive error without exerting any accommodative effort to tell that. Accommodative effort may deceive you because it may tell you pseudomyopia if it's over accommodating in an emmetrope, or it can tell you less hypermetropia than the real if it caused compensation of some hypermetropia by accommodation. So if atropine is used, it causes complete relaxation of the ciliary muscles. But the problem is it's a very strong cycloplegic drop, but it's very weak dilating drops, because you will never see a patient fully dilated under atropine eye drops. Atropine usually causes mid-dilated pupils. So if you are going to examine the periphery of the retina or to see the periphery of the fundus, it's not the ideal one to examine with atropine. Atropine causes mid-dilatation, but maintained. The other pitfall is it works slowly and it's maintained for 14 days on the average, because it may affect the dilated pupil and cycloplegia effect of the ciliary muscles for 1 to 2 weeks, and it may extend in some cases up to 1 month. The other character of atropine is it has a cumulative effect, because usually when you put atropine, it's accumulating because of the long duration of action. So if you are using atropine to cause complete cycloplegia, you need to use it 3 times daily for 8 days. But from where did it come telling 3 days? 3 days, actually the maximum effect of atropine happens within 3 days. And from the 4th till the 8th day, it's a very, very minimal, non-considerable effect. So to get an idea about the complete refractive error, you have to give atropine 3 times daily for 3 days to get out with the outcome of complete cycloplegic refraction. But do you need this complete cycloplegic refraction in all cases? Let's compare with other drops. So atropine, if you used a child for cycloplegia, you have to put it for 3 days, 3 times daily, and you have to counsel your patient. It will be maintained for 1 to 2 weeks and sometimes maybe to 1 month. Then came the other type of drops, which is less effective and it's no more used nowadays, which is homatropine. So will not waste our time speaking about it. But let's go to the most popular one, cyclopentolate. Cyclopentolate mimics atropine in its effect. It's a very strong cycloplegic, but it's a very weak dilator as well. It belongs to the same category of parasympatholytics. It acts for 18 to 24 hours, but mainly it's a cycloplegic effect. A bit weaker than atropine, but if you want to get the cycloplegic maximum effect of cyclopentolate, you have to put it only for 2 times. At moment 0, and then the second drop will be put after 5 minutes, and you can check your refraction from 35 minutes till 55 minutes after putting the first eye drop. So its results usually mimics or very near and close to atropine effect. So no more wide use of atropine nowadays, except in very exceptional few cases. The effect will last only for 24 to 24 hours, so less uh, loss of accommodation. The patient can go back to his school or to usual life after 1 day. The problem of cyclopentolate is it sometimes, especially in children younger than 7 years, it crosses the blood-brain barrier. And if you put more than 2 drops, it will cause, in many cases, hallucinations and extrapyramidal manifestations, which may extend to convulsions or loss of consciousness. So please don't be that generous in putting cyclopentolate eye drops, especially in one of the exceptional scenarios when you are using it for dilating eye drops. Your nurse will tell you, I put 2 times or 3 times cyclopentolate and the pupil is not properly dilated. So you tell her, please put more and more and more. So it will never affect cycloplegic effect more, and it will never dilate the pupil more. So if you want to use dilating eye drops, cyclopentolate and atropine are not the best options to do that. To come again with the tropicamide. Tropicamide is the same category of parasympatholytics, but it's a very strong dilator, very weak cycloplegic drop. So it's very commonly used for dilating eye drops. It has minimal systemic effects, and it will never cross the blood-brain barrier like cyclopentolate, and its systemic effects are much, much less than that. The third privilege is it lasts only for 4 to 6 hours as a dilating drop and 6 hours as cycloplegic effect. So it's not the best option if you are seeking cycloplegia, especially in accommodative esotropia or in pseudomyopia, or in a new patient coming for you in the first time and you want to know a good idea about the refractive state. But it's one of the best options as a dilator, and a cycloplegic, it's an intermediate drug. I forgot to tell you about atropine. Atropine is very safe cycloplegic, but the only pitfall, which is very popular, it causes fever in some children. And it may cause redness, flushing in some children. And actually, it's innocent symptoms and self-limited. Just go for supplementation and it will pass without problems. Don't put too much, especially in very young children under the age of 1 year. Better to use less concentration. Many times in the past, we were using atropine ointment, but I think it's not that popular in most of countries nowadays. So if I am going to, my best option is to use cyclopentolate because it has a relatively less duration of action. So I can use it only for 1 day, putting spaced by 5 minutes, and I can check the refraction after 35 minutes from the first drop. And in most of cases in which I'm not interested to or very close to atropine effect. Many times in my real practice, I want to see both cyclorefraction and periphery of the retina. So usually I ask my nurse to put cyclopentolate twice and let the third time to be tropicamide to get with the dilating effect. So I can do the cycloplegic refraction and tropicamide as well. So I will come with the results of the refraction, either by retinoscopy or autoref after the cycloplegic eye drops. Then we have 3 main questions in today's lecture. To prescribe glasses or not, which lens power to use, what's the best design of the lens to use that parents will ask you about. So let's go again, to prescribe or not. So questions will fly in my brain telling, is there a refractive error within the normal range for age or not? And so will this child's error emmetropize and it will be normal in the future? Will this error disrupt the development of normal vision? And will it prescribing glasses will improve visual functions or not? So these are questions that will fly in my brain. And I have to go for revising what is the basics of the refractive errors in the children. So ask yourself again to prescribe or not. So is the refractive error within the normal range for age or not? So we have to know what is the normal range of refraction in children. Usually from birth to 3 months, most children are hypermetropes and hyperopia of an average of plus 2.16 with a standard deviation of 2. from third month till end of the first year, there will be rapid decrease of hypermetropia. Average error at the age of 9 months will be plus 1.36. But after the age of 12 months, it's very slow change in refraction till the age of 2 years in myopes and 4 years in hypermetropes. So if you saw a newborn with a plus 2 or 3 or 4, so it's still within the normal range. And if you saw him with decreasing hypermetropia and you found him at the age of 1 year was +2, still it's fine. So this is the normal range of refractive errors in the children of normal children. Again, is this refractive error within the normal range or not? So few infants are myopic at birth. Most of those who are either myopic or hypermetropic will be normalized or emmetropized by the end of the first year. The rate of emmetropization is generally proportional to the initial error. And this is very important to know because if you have two children, one of them cycloplegic refraction of whom is -1/2 or -1. The other one is +7. So that child with -1/2 or 1 have a greater chance to be emmetrope in the future other than that one with +7.
لا
So the more
طبعا.
deviation, from normal, the less a chance to emmetropize or normalize in the future. So those who start off close to emmetropia or with a low amount of hypermetropia show little change and vice versa. Emmetropization means that changes in keratometry that will flatten the cornea. Keratometric values and axial length will change, opposing consequences for the refractive state of the eye. So flattening of the cornea will take you on the path of hypermetropia increase, and the increase of the axial length will take you to the path of myopia increase. They should be equal in the normal situations. So the emmetropic child at the age of 3 will remain for life emmetrope as a real ideal typical scenario. Increasing axial length will lead to myopia, and keratometric flattening will lead to hypermetropia. Who will exceed the other? We don't know. This is the normal range of axial length at the newborn, which is 16.8 millimeters. In adults, it's about 23. So passing from 16.8 till 23 will take you to the myopia side. On the other side, your keratometric readings at the newborn are 55, and the average of adults is 43. So opposing forces will tell you should be remaining emmetrope all the time. Who will exceed the other one will win the game. If cornea flattening is more, this hypermetropia will increase, or axial length increased, myopia will increase more. And this is emmetropization. Going back to our lecture, to prescribe or not, this is the question. So will this error disrupt the development of normal functions? This is the main question, because in a normal child, if he's less than 2 years or 3 years, he's not driving, not studying, he didn't go to school yet, and he has no much details of interest. But if it's disturbing the development of normal functions, you have to give glasses to stand against occurrence of amblyopia. So partial amblyogenic refractive errors or potentially amblyogenic refractive errors are myopia more than -5, hypermetropia more than +6, because if myopia is more than -5, the child will make the image, all pictures close and close and more close. But if it's exceeding -5, he will not see clear. So it will be in the amblyopia way. Hypermetropia can be compensated by accommodation, but if exceeded +6, it will be amblyogenic. Astigmatism more than 2.5 diopters, either plus or minus. Anisometropia more than 3 in myopia, 2 of hyperopia, 1.5 in astigmatism. So if you have anisomyopia, anisohypermetropia, or anisoastigmatism, you have to know these numbers to give glasses. Let's say if I have a child less than 1 year with myopia more than -5, I should give glasses to stand against amblyopia. If hypermetropia more than +6, I should again give glasses. If you have astigmatism more than 2.5 or anisometropia more than these numbers, Let's give one example just to tell you about astigmatism. If you have a child with bilateral astigmatism of -2 at the age of 14 months, I think I can defer prescribing glasses. I can wait. But if he has one eye completely immetrope and the other one was -2 astigmatism, I should give glasses because of the anisoastigmatism in this child. Then you will prescribe glasses, but when will you prescribe? Because you'll find much resistance from the child and his family telling you, please don't give us glasses, but you have to have a clear, good answer. Again, if you have myopia more than -5, from below age of 1 year, more than -4 from the age of 1 to 2 years, and more than -3 if you have more than 2 to 4 years. In hypermetropia, if you have hypermetropia more than +6, means below the age of 1 year, more than +5 from 1 to 2 years, more than 4.5 diopters if more than 2 years. In astigmatism, 3 diopters below age of 1 year, you have to give glasses. 2.5 from 1 to 2 years, 2 diopters more than 2 years of astigmatism. This is the table of anisoastigmatism or anisometropia, I'm sorry. In anisometropia, you have a range according to age. So this is how to prescribe glasses. And finally, I'll give you the summary of all these numbers in a table, and I advise you all to keep it with you. Then you have your cycloplegic refraction. Which power to give? You decided, okay, you will go for glasses. But what's this protocol of Atkinson protocol? What is the power to prescribe for children? And I will just stop here for very few seconds to tell you something, because from where did these numbers came? These numbers came, actually, it's called practice experience. If you went back to the American Academy or APOS or recommendations of main societies of pediatric ophthalmology practice, you'll find many guidelines and instructions according to literature, and it's evidence-based medicine. But in occurrence of amblyopia due to refractive errors, we don't have a certain clear protocol for a research telling you these guidelines. So it came out from multiple multi-center practice experience to give these guidelines and numbers. So which power to prescribe? In myopia, if you are dealing with a child preschooler, less than 4 years, in myopia, you have to go for -0.5 to -1 under correction below the school age, and full correction from the school age and above. So if you are giving myopic correction in a preschooler, give some under corrections. And recent research about progression of myopia are recommending under correction for delaying the progression of pathological myopia. But in a schooler one who exceeded the age of 4, now he wants a clear image. So if you did under correction of -0.5 or more, he would be fogged and not seeing well. So give the full cycloplegic refraction for a schooler or according to your trial. In hypermetropia, if you are dealing with a child who is orthotropic, I don't have any exceptions other than refractive error in these cases. So if you are dealing with a hypermetropic child, please do 1 diopter under correction of the full cycloplegic refraction below the age of 6 years, and full correction from school age and above. And in astigmatism, give 1 diopter under correction below the age of 4 years and full correction from age of 4 and above. In anisometropia, full correction of significant refractive anisometropia should be considered as early as possible. Because, as you know, the anisometropia is one of the main causes of very resistant amblyopia that is rapidly occurring, and if you didn't discover well at the proper time, you will lose the good vision in that eye. In anisometropia, full correction of the axial refractive error in both eyes with glasses can be achieved to a high extent. Because one of the misconsiderations in pediatric ophthalmology practice, these are wrong numbers for glasses. If you saw this picture, telling the right eye is myope of -1, the other is -9. So you gave these glasses for a child. They will tell you this is the wrong glasses. So don't give it because you have a difference more than -4. And it's not accepted to have this -4. The basic books of optics. Because in such classes, you are scared of anisoconia, diplopia, and the image size. But if you return it back to textbooks of optics, it will tell you anisometropia will never cause anisoconia. So in axial anisometropia, you can give the highest numbers you can without occurrence of anisoconia. Why? Because the magnification of the lens will never happen. It will occur only in index myopia. So if these numbers are for a child with axial myopia of -9, it's fine. But if it's some index or refractive myopia, you shouldn't give these glasses because of anisoconia will happen and it will disturb the visual functions of the patient. So children usually tolerate high numbers of anisometropia, and there is no anisoconia in axial ametropia. One of the symbols I'd like to tell in this lecture is the projector of the lectures. So if you have a projector placed 1 meter from the screen, and you decided to take it back 1 more meter or 2 meters, the image will be fogged and will be hazy. And if you return it back to focus the image again, it will come again to its normal image size. So don't worry about anisoconia in axial myopia. Again, which glass is designed to describe for the patient? Because parents will keep asking you. We have to go for which frame. And in choosing our frame of the glasses, we have smaller frames are advised for high power lenses because it will cause less lens thickness, less peripheral lens aberrations. So the more power you have, try to go for smaller frames as possible. Again, children are very resistant to using glasses. Even don't be deceived if they are attracted to use glasses in the start, because they will come to resist again after using it for a short while. So most kids get at least a little teasing about their specs, especially the first time they wear glasses. So it's very important that they avoid frames that make them look uncool. The frame material should be plastic rubber or something can't be broken. Better choices for children because they are considered more durable, less likely to be bent or broken, lighter in weight, and less expensive. Nowadays, manufacturers are making metal frames that incorporate these features, but again, it's not that safe like rubbery or silicone frames. You have to respect the design of the glasses, especially about the nasal bridge fitting, because it's one of the most important factors of patient resistance, because one of the toughest parts about choosing the suitable frames for young children is that their noses are not fully developed. So they don't have a bridge to prevent plastic frames from sliding down. So try to avoid this picture of the sliding frame over the nose. Again, tight frames will cause disturbed ear uh, comfort because of the back strap or cable templates. The lens material, they will ask you with glass or plastic ones. The best one in the past were polycarbonate or Trivex. It was significantly lighter than plastic, scratch resistant, manufactured with high UV protection. Price is comparable to usual plastic lenses. But over the last couple of years, a revolution happened in the lens material because they came with very high index lenses and less magnification. So we have now many manufacturers of the very popular companies telling you they have very, very thin lenses. Nowadays, I see lenses of power plus 20 or 16 in phakic children with a very thin lens thickness. So to conclude, refractive errors should be properly corrected as early as needed to avoid amblyopia. Anisometropia is an added risk that enhances the development of amblyopia. Close regular follow-up of the children with higher refractive errors is mandatory as they are less likely to emmetropize. And this is the conclusion of this lecture, because if you want to come out with single piece of knowledge, I advise you to take this one and put it in your all clinics, because this is a summary of guidelines for refractive correction of infants and young children, which refractive error to correct and what to neglect, especially in these cases. Finally, proper choices of the frame size, color, material design is very important, as well as the lens power and material. Parents' education regarding the importance of glasses, and particularly in the follow-up, is crucial part of treatment. Thank you very much for your attention, and I think the discussion after that will be about glasses in special situations in strabismus, because I don't like to put it in the main lecture, because we can go through different discussions about using glasses in the children of special situations. Thank you very much.